Welcome back to Thrani, I'm Joe B. Today we'll go over manual techniques and exercises to regain pain-free shoulder motion after SIRVA. Let's dive in. Shoulder injury related to vaccine administration, or SIRVA, occurs when the vaccine injection goes into the shoulder capsule rather than the deltoid muscle. The cause of this can be due to incorrect technique or landmarking for intramuscular deltoid injections, such that the injection ends up being too high or less than 2 finger breadths below the acromion. SIRVA can bring about a robust immune-mediated inflammatory reaction that appears 48 hours after injection, which can result to shoulder bursitis or adhesive capsulitis. Over-the-counter medications may not help, and history taking will reveal no known trauma. If the injection also hits the radial or axillary nerve, patients can complain immediate burning pain during injection. Signs and symptoms can last from 48 hours to 6 months. And MRI or ultrasound can reveal positive shoulder capsule or bursal inflammation. The assessment for SIRVA will yield positive Neers, Hawkins-Kennedy, and Yoakum's test. In terms of range of motion, shoulder flexion and abduction can be limited to as low as 45 degrees and extension to 20 degrees. In addition, external and internal rotation may also be limited. Muscle strength, however, is preserved. To treat SIRVA-induced limitation of motion, you need to perform glenohumeral posterior glide to improve flexion and internal rotation. The anterior glide can also be performed to improve extension and external rotation. And finally, the inferior glide to improve abduction. To perform glenohumeral posterior glide, the patient will be in supine with treated shoulder flexed to a tolerable range and elbow flexed. The therapist is on the treated side with the patient's lateral arm at the therapist's belly. The left hand is placed on the anterior axilla while the right hand cups the elbow. The therapist flexes her trunk forward or bows to cause glenohumeral distraction. After that, the therapist bends both knees or squats to cause a posterior glenohumeral glide. The position is held for 30 seconds for 3 to 5 reps. To perform the glenohumeral inferior glide, the patient still will be in supine with the shoulder placed in scaption or abduction up to tolerable range. The therapist is on the treated side with patient's arm supported by the right thigh. The therapist's right hand is placed in such a way that the right thumb is lateral to the acromion, while the left hand supports the arm at the elbow. The therapist shifts her body weight to the left hip to provide a distraction force, then rotates the torso to the left to allow the right hand to cause an inferior glenohumeral glide. The position is held for 30 seconds for 3 to 5 reps. To perform a glenohumeral anterior glide, the patient and therapist position as well as the manual contact is the same as the glenohumeral inferior glide. However, in terms of technique, after distraction, the therapist now extends the trunk to provide an anterior glenohumeral glide. The position is held for 30 seconds for 3 reps. Upward rotation mobilization of the scapulothoracic joint can also be performed to allow optimum subacromial space during elevation of the arm to reduce reinflammation. The patient position is in side lying with the treated scapula uppermost. The right arm is cradled by the therapist's right forearm, and the therapist will be in front of the patient with the left dorsal web space placed at the inferior angle of the scapula. while the right lateral forefingers will be placed above the scapular spine. For the technique, the therapist shifts her pelvis to the right and then rotates her torso to the left. This is performed while the right hand delivers an inferior medially directed force to the spine of scapula, and the left hand delivering a lateral and superior force to the inferior angle of the scapula. The position is held for 30 seconds for 3 reps. Exercises can be provided, like a cross-arm stretch, for flexion and internal rotation retention of motion. For shoulder extension and external rotation retention of motion, a doorway stretch can be utilized with a 3-way progression as per patient tolerance. For functional hands behind the back motion, a stretch can also be performed for that. All of these exercises are held 30 seconds hold for 3 to 5 reps. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.